Good morning, everybody. Welcome to the Winnipeg Carcinoid CNETS Canada Carcinoid Neuroendocrine Tumours Society Canada conference, and it's wonderful to see everybody. My name's Maureen Coleman. I'm president of CNETS Canada. CNETS Canada's come a long way, and we're going to keep going. We're going to keep going. We're going to keep on keeping on, because there's so much to learn about neuroendocrine tumours. The title of this conference is Neuroendocrine Malignancies, the Carcinoid Tumour Spectrum, with a look at pathology and some present and emerging modes of treatment. I'm going to introduce Jim Cormus. We're talking just for a minute because so much is happening, who will say a little more. And then we'll take a couple of turns, and that's it.
Good morning and welcome. This is true. I'm here now. We were very, very pleased to be able to pull together a representative group that we hope best reflect the challenges, opportunities, and best practices currently available locally and internationally. Be they patients, be they medical professionals, or pharmaceutical representatives or regulators, we try to be as inclusive as possible. We invite you also to be active participants in building a creative strategy to move forward on behalf of our growing NET community. To do this, we have a question-answer period built into the program for later today, and that is with a panel of experts, so we invite your input. And we invite that in a formal way by providing file cards will be available on all of your tables during the course of the day. We invite you to put down questions you have. If you have any proposed suggestions for remedies, we're always looking for those creative ideas. And then when you have those, if you could give them please to our secretary for CNETS Canada, Alyssa, just hand up so everybody knows who you're giving your card to, and then she'll make sure our panel of experts get those in time for review before this afternoon so they can give a fully informed and reflective response to that. We want to thank the pharmaceuticals and our sponsors for being with us today, and we're just absolutely delighted that everyone's here.
Yes.
Thank you, and enjoy.
So I'd like to welcome everybody here to Winnipeg. Those of you that are Winnipeggers, outside is perfectly normal for May. Those that have journeyed from afar, we apologize, but it is Canada, it is May, and snow can be expected. Too bad we didn't have this last weekend when it was 24 degrees here. I've been tasked with a kind of a difficult topic, considering that they've asked me to do in 20 minutes an overview of neuroendocrine tumours. So I apologize to any of the speakers ahead of time if I've stolen a bit of their thunder, but essentially I'm just going to give a very brief overview of neuroendocrine tumours and then segue into the invited speakers. So those of you that were here in Toronto 2 years ago, I showed this slide when I introduced the talks, and certainly thought it was very appropriate to show a picture of zebras, given it is the mascot of this organization. This was actually taken on my honeymoon. I dragged my wife to Kilimanjaro. How many couples on their honeymoon get to sleep in separate beds and not shower for several days? It must have been true love, since my wife's idea of roughing it is not having a jacuzzi. And so this is the Serengeti just as the rains are starting to hit, because that was the second part of our trip. So neuroendocrine tumours are a real grab bag term and often are mixed up. And They're basically endocrine tumors of the GI tract. They're extremely heterogeneous. There's lots of different patients that are involved, have this disease. And they're collectively known as neuroendocrine tumors. And this is a relatively new term trying to standardize everything. They consist of the islet cell tumors of the pancreas, which either secrete or do not secrete hormones, pheochromocytomas, which are tumors of the adrenal gland, medullary tumors of the thyroid, which are now, at least in Manitoba, are now starting to be managed by the medical oncologists. They're extremely rare. And of course, carcinoid tumors, which are the majority of the neuroendocrine tumors. They are relatively uncommon, even in the GI tract where they're mainly found. They only constitute about 2% of all malignant GI tumors. And the incidence varies depending on which series you're looking at, but still relatively common, and they're less than 0.25% of all cancers. So they're relatively uncommon. However, the prevalence of this is higher because these patients, even in the presence of metastatic disease, i.e. a disease that's beyond the chance of cure, survive for a long period of time. So in my clinic, we have a fair number of patients, even though there are not a lot of them, because they do so well. And they're divided roughly into tumors that are slow-growing versus tumors that look poorly differentiated. In other words, they look aggressive under the microscope. And they're characterized as functional, in other words, secreting hormones such as serotonin or bradykinins, and non-functional, so tumors that just cause problems by local effects. The World Health Organization has classified these tumors into 3 basic groups, the WHO nomenclature is in the middle, and the common synonyms, so what we use in the clinic and what our patients use, is on the right. So we have the well-differentiated tumors, the ones that look quite slow growing, and they're typically called carcinoids. We have the well-differentiated neuroendocrine carcinomas, in other words, tumors that exhibit malignant behavior. And then we have the poorly differentiated neuroendocrine carcinomas, which undergo a whole pile of grab bag terms, but malignant carcinoids, small cell cancers. The classification, some of these tumors are notoriously difficult to classify. Are they cancer? Are they not cancer? And even tumors that are less than 2 centimeters, which we traditionally think is benign, can sometimes exhibit malignant behavior. But there's certain things that we look for, including the size of the tumor, evidence of invasion and local spread, evidence that the tumors under the microscope look aggressive, and of course, if there's any spread to other organs, such as the liver or within the abdominal cavity, then that's certainly characteristic of a malignant behavior. Recently, the European Neuroendocrine Tumor Society has proposed a standard system of staging in which we look at the tumor itself, the presence or absence of the lymph nodes, and the presence or absence of metastases. And the TNM staging system is what we use for almost all other cancers. There's a number of them. I didn't actually put them up. They're addressing a number of the different types of cancers. And currently, to my knowledge, they're still undergoing clinical validation. In other words, they proposed the system. Now they have to figure out, does it actually help us in determining prognosis and treatment? However, it does not distinguish whether these tumors are producing hormones or not. It does not distinguish whether the main tumor cell type or the genetic background of the patient. So there are some difficulties with this system. I'm not certain we're ever actually going to get a very good validated system. This will be an international effort. Both the Europeans and the North Americans will need to be involved due to the relative rarity of this disease. The same group, the European group, are also proposing a grading system, grades 1 to 3, and depending on what's called the mitotic count, that's 10 high-powered fields. For some reason they got deleted, and the Ki-67 index, which I'll talk about, and also I'm sure our next speakers will talk about as well. So the tumors are spread all over the place. Typically we think of carcinoids and neuroendocrine tumors arising somewhere in the GI tract, but they do arise in other places, the lung specifically. About 10% of my patients their tumors start in the lung, and they behave sometimes in a different fashion than the ones in the GI tract. There is some controversy over where the most common part is. Traditionally, it's been the appendix, because of lots of people get appendectomies and we find these small little tumors stuck there. We don't know what the clinical significance of those are. We also have carcinoids arising in other areas. I have at least 2 patients in my practice whose carcinoids arose from the ovary. But they typically arise in the GI tract, and the majority of the ones that don't arise in the gastrointestinal tract arise in the lung. Their clinical features can be very, very difficult to determine. They can be, we have a number of patients in which they didn't have any problems until they got a routine scan or a routine x-ray and it was found. They can present with very vague, nonspecific symptoms. I've got a little tummy bloating, I've got a little cramping, a little weight loss. Or the tumors may get to a point where they actually block and cause obstruction, and that's when they come to the attention of the physicians. I've had 1 or 2 patients in my practice that have had an MVA, and they got a CAT scan because they had trauma from a car accident, and that's how it was found. In the pancreas, these functioning tumors produce a whole pile of clinical symptoms and syndromes. We are required to learn about these in medical school, and then, of course, we promptly forget them until they go into the subspecialties. But in the pancreas, they're notorious for producing insulin and gastrin and glucagon, and there's a whole pile of these syndromes. But they're quite uncommon. And then the other tumors in the pancreas are basically non-functioning tumors, so they're tumors that just don't produce any hormones but cause problems through growth and invasion. The carcinoid tumors, which are the majority of the neuroendocrine tumors, is a relatively old diagnosis and was actually termed carcinoid by Oberndorfer in 1907 because at that time they were felt to be, he was saying they were cancer-like. That's what carcinoid means, to describe the relatively benign nature of these tumors, behavior of these tumors. The diagnosis in North America, this is the SEER data, is increasing, probably in part due to increased detection. I'm not certain whether there's actually a true increase in the actual numbers of these patients, but probably we're detecting them, there's no true increase in the disease. We're just seeing more and more of these patients because we know what we're looking for now. Like I said in the previous slides, this is a bit higher. This is the SEER data. About 28% arise in the lungs. I think that's probably a bit higher than what I've seen in the past, but the majority of them rising in the GI tract. About 10 to 15% actually present up front with metastatic disease, but the overall survival is still good regardless of where these tumors arose from. The natural history of these is that they remain asymptomatic for a long period of time. Then they spread. Then they cause the carcinoid syndrome, flushing diarrhea, and so there's tends to be a long preclinical, pre-diagnostic history where these tumors grow and then they spread. Many of these tumors are discovered by accident. When the symptoms occur, they can occur from a number of reasons, from the actual tumor itself, from damage from the tumor causing fibrosis and scarring in the GI tract, causing severe abdominal pain. And then, of course, we get the carcinoid syndromes, where these tumors produce all these compounds and cause the carcinoid syndrome. And now we are having more and more incidents of patients contracting carcinoid heart disease, which is disease of the fibrosis of the valves from chronic secretion of serotonin. And this is becoming a major problem in the management of our patients, and it's also now becoming a major cause of death. And then carcinoid crisis. I've not seen a carcinoid crisis in a long time, but basically that's when these tumors produce a massive amount of hormones, and patients actually just drop right in front of you, and they can actually die from the hormone secretion if this is not recognized and treated right away. So the clinical presentations, like the non-functioning, is often incidental. There's the mass effect or intermittent bowel obstruction from these mesenteric fibrosis that cause this nasty scarring within the abdomen. And that's what it actually looks like here under CT, where this tumor is here, and a lot of fibrosis. This is something we have to try and prevent. And this is why when I see patients with tumors in this area, I send them to the surgeons to try and ask the surgeons if they want to see if they can remove these tumors to prevent the scarring. The carcinoid syndrome causes flushing and all these quite classic symptoms. It's thought to be due to the bradykinin release. And there's two types of it. I apologize for these slides. Obviously, I did these on my Mac, and this is not a Mac. So they did not, obviously they didn't transfer well. So this kind of general flushing, which I have seen in some of my patients. And then there's the more prolonged flushing, which produces this chronic look on the patient's face. And chronic changes like this. There's diarrhea, which is related to increased gut motility due to the secretion of serotonin, and it does not correlate with the flushing. You can get the diarrhea and the flushing independently. Then there's carcinoid crisis, which I've mentioned, where we can get life-threatening reactions. It's important also to identify patients with this condition because it can actually be precipitated at surgery. Okay. So the classification of these tumors, basically we divide them up into three depending on where they are in the embryology. This is the foregut, which is the lung, stomach, and pancreas. The midgut, which is where the majority of these arise, so the small intestine and part of the colon. And the hindgut, which is the distal part of the colon and the rectum, and these are about 15%. So the majority of these are actually in the middle. They can be functioning versus non-functioning, so they can secrete a whole raft of different types of compounds which cause problems. In the foregut, they're more likely to produce certain hormones. The midgut is where we see the classic carcinoid symptoms of hot flashes, wheezing, and diarrhea. Although hindgut, the tumors in the distal colon and rectum classically do not produce these hormones, I think we've all seen them in our practice where people with hindgut tumors actually do present with carcinoid syndrome. They're not that common, but they do occur. So these biochemical markers, which I think I will defer because I believe Dr. Azat and crew will be talking about this. Yes, okay. So I will leave that and I will go to, where are we here? And I will not talk about Ki-67. Sorry, guys. Let me just get all the way to the end of this talk, because all this diagnostic imaging will also be talked about by the later speakers. I just want to go to the last. Here we are, principles of management. So in conclusion, I just wanted to briefly put this slide up. And the moral of this slide is never, never try a new PowerPoint system at the last moment when you're trying to do slides for a talk. So I actually was up at 6:30 this morning, went into my office with a good old PowerPoint from IBM PC and did this. So I wanted to put this up as a kind of a general segue into the next part of the talk. This is actually the latest recommendations from the Canadian group. The Canadian group met in a number of meetings consisting of medical oncologists, radiation oncologists, nuclear medicine specialists, and surgeons. And this was we had previously published these Canadian guidelines in Current Oncology a number of years ago, and these will be going into Current Oncology probably in the next few months. It was a consensus meeting of all of us to try and integrate the new data, the PROMID data, which Dr. Arnold will be talking about later, and other data from other clinical trials. So this is basically a summary of the consensus, and And we have added that basically the new stuff is the PROMID data, where non-functioning or midgut tumors now are offered somatostatin, SSAs, because of the increase in progression-free survival. And we've also put into this the role of Ki-67, which will be discussed later, which is a nuclear marker, and helps us determine whether or not these patients should be treated with chemotherapy, observed, and helps us also to determine the natural course of this disease. So this is the latest iteration, and this is the one that's going to the journal for publication. It's not a confidential situation, so I don't feel that I'm obliged to not show it. It actually shows us how difficult the management of these patients can be, because there's so many different arrows and so many different options for these patients, which is part of the management. It requires multidisciplinary approach using both the medical oncologists, the nuclear medicine physicians, as well as the surgeons. So with that, I will ask for our next speakers, which are Dr. Azat